Thank you very much for the opportunity to present our data. We had the privilege to be the first who were able to implant the Impella 5.5 around Easter these days, and we are also looking very forward to the collaboration with Abiomed and the engineers to further improve the device. And I would like to share with you our experience we had with the first implantations. So I would like to start with the Impella 5.0 device, which provides up to 5 liters a minute. And you all know this device, and it's a 21 French microaxial pump, and it was originally designed for femoral access, but it's also possible to implant it by axillary approach. And you see it on the right side. This was a patient who presented with cardiogenic shock, lactate of 10 by ventricular failure. We implanted the Impella 5.0, and one of the advantages is that you can easily mobilize patients. Here you see the patient walking around on our ICU on the third postoperative day with the physiotherapist and the nurse. And we see this, we feel that this is one advantage over femoral access in those very sick patients. And we know that the results are quite good with the Impella 5.0. This was a meta-analysis, and I would like to highlight those included in those patients in this meta-analysis were patients with femoral access and also axillary access, and for different diagnoses. And as I said, the results are quite convincing. However, the pump itself has an CE approval for up to 10 days, and we looked into our own data, and more than 70% of our own patients were in need of a longer support, longer than 10 days. And what are the potential problems? Fortunately, we rarely see complications with longer duration of support with the Impella 5.0, but there are potential and rarely seen complications. As you see on the picture, there's a thrombus on the pictal catheter, and there's also thrombus formation in the prosthesis along the repositioning sheet, and this was addressed by the Impella 5.5. So the Impella 5.5 provides hemodynamic support up to 5.5 or even 5.8 liters, depending on the afterload, and it's designed for a duration up to 30 days. Again, it's a 21 French cannula mounted on a 9 French catheter. It's designed for only axillary implantation. It has, in contrast to the 5.0, it has a fiber optical pressure sensing. And the modification, the lack of the pictal catheter, and I will show you some fluoroscopy images, provides and improves the deliverability of the pump. Here you see a comparison between the 5.5 and the 5.0. The motor housing of the 5.5 is shorter. As I mentioned, it has this optical sensor. You see it on the picture below. The pump itself is stiffer, which made it even easier to implant. The 5.0 is also easy to implant. It has a new designed motor, and it has a low purge flow, which allows longer support durations. And the repo sheet does not exist anymore, which should also facilitate long-term support with the 5.5. And importantly, it's designed for axillary insertion only, as I told you. Here you see the device. It's now comes in whole, so there's only the purge line needs to be attached to the pump. And you see the summary. Again, a shorter device, almost same size. It has no pigtail anymore, and the sensor is fiber optic sensor. Coming to the first patient we implanted, it was a 75-year-old patient. He had a 10-year history of ischemic cardiomyopathy and severe functional mitral regurg. And he was non-invasively ventilated, was treated for a pneumonia, and the ejection fraction was 18% with the dilated left ventricle of 75 millimeters. And importantly, from a technical aspect, he has a CRT device on the right side and abandoned leads on the left side. So we decided to implant the Impella 5.5 on the left side. Usually our protocol is to go for the right side we think this is of advantage. We can discuss it later. So here you see the first implantation. I'm sure you are all aware of the principal technique. So the catheter is pushed through the aortic valve, and it's then changed to the 5-5 wire, and then the pump is inserted, as you can see here. Again, this shorter and stiffer device facilitated implantation of the device, and it was quite easy to implant the pump, and now it's in place, and we started to treat the patient. So it provided flow from up to 5.5 liters, and it could be implanted by a small incision. And here you see the chest x-rays from pre-implantation, and the patient was congested, and that improved even within 24 hours. So we can extubate the patient easily, and his pulmonary function improved, and also his end organ function improved. I will show it to you later. So we can address his functional MR by implanting a mitral clip, which was also possible under Impella 5.5 support, as you can see on the echo images here. And the patient was weaned off any inotropes, was weaned off non-invasive ventilation. He could be mobilized to chair. Unfortunately, the patient developed acute abdominal pain, and the reason was an appendicitis, which led to the death of the patient due to sepsis, unfortunately, but this was not related, as far as we can investigate it, to any adverse events to the pump. So the second patient was a 50-year-old male patient, also ischemic cardiomyopathy, and a history of CABG and mitral valve repair. He had an ejection fraction of 10%, again, very dilated left ventricle of 95 millimeters. And he decompensated, was treated by Impella CP for 10 days. That was explanted, the Impella, and clinically he did well at first. He was in need of dialysis, but he decompensated again, mainly due to ventricular arrhythmias. So we need to resuscitate him for like 5 to 10 minutes. We implant an ECLS in the femoral vessels and also the Impella 5.5. And there's another advantage, I told you that. So I think it's important to properly place the pump even for longer term support. And by the lack of the picture catheter, it's easy to reposition, and the talkability is very, very good in this new device. So the patient decompensated due to ventricular arrhythmia. We took this patient to the EPU cath lab, and you can see on this small video, we performed an endocardial ablation. You see the potentials we measured in this patient, and our electrophysiologists, and we submitted this manuscript just recently, and they say it's much easier because of the lack of the picture catheter to measure endocardial potentials. With red, you see the scar. We treated the scar, and by doing that, we were able to remove the ECMO because of a stabilized right ventricular function. And the patient was on dialysis before or after his first decompensation. And during Impella 5.5 support, you see it in the upper graph, the creatinine came down, the renal function, the end organ function recovered. After 21 days, unfortunately, the ventricle did not recover, so we implanted after 21 days as a redo procedure HeartMate 3 device. So the patient is nowadays, after 7 months, without any complications, stable and at home with his durable LVAD. And interestingly, by improving end organ function with first the Impella 5.5 and then the LVAD, his creatinine improved to a creatinine level of 1.3, and the patient is now off dialysis. So I want to give you an overview about the 4 patients we implanted in Hamburg out of 6 that have been implanted so far. 2 patients died, unfortunately, due to septic complications unrelated to the pump, and 2 patients with support duration of 29 days, and the other patient that recovered after 8 days are doing well, so a mortality rate of 50%. I would like to conclude that we implanted the first Impella 5.5 patients in Hamburg that was successfully treated in terms of end organ recovery. We did not observe any adverse events related to the pump, and we believe that the Impella 5.5 expands the spectrum of short-term devices. The technical and design features further facilitate the ease of the implantation technique, and we believe that the indication may further expand even for even longer support and indications. Thank you very much.
Thank you for a nice presentation, and congratulations on dealing with these difficult patients. I want to pick up on your last comment on your conclusion slide. You said that we might go for longer implantation. Now, I know that the device is approved for 30 days, but just imagine it's approved for whatever you want clinically. How long do you want to have a device like that to solve clinical problems? Is that 3 months, 4 months?
Actually, we don't know, but it's good to have a device which gives us the option to do so. And I think we will hear later on talks about myocarditis, and it's sometimes the ventricle needs a longer time to recover. So I think it's very good to have a device which allows us to decide when the device can be explanted or changed to another device. So it's good that we are the ones who decide how long the device stays in, and not the device decides for us. Yeah.
If I might just add, I'm sure in the past we often put LVADs in patients who actually didn't finally not need an LVAD, but could be recovered. Because we just have a short window in this crash and burn patients. What to do with them, then you finally decide to put an LVAD in. So devices like this, and to your question, I think it would be desirable if you have it in for longer, because patients can be moved around, as you saw on the pictures, and it takes sometimes 1 month, 2 months to decide whether the patient can recover or not. And we are just working on recovery protocols together with Dan, and hopefully we'll be a little bit smarter for the next AQ meeting, when to decide, put an LVAD in or wean the patient.
Mark?
Congratulations. I have some concerns about having the catheter in the axillary artery for extended period of time. If you're talking about going beyond 30 days, going out to 180 days or a year. So that pump looks like you could put it in like the LD and directly into the ascending aorta via a graft. Do you have any thoughts on that?
Sure, you can. The question is, if you talk about longer duration, so we can tunnel it and it comes out. The question is, where comes it out? Is it of advantage over the right axillary artery? At least we don't know. It's certainly possible, yeah. But the thing is, to add this, what we try to do, especially for those patients we've seen it on a video, the explantation can be easily done under local anesthesia, and it's maybe also possible after stenotomy, but it's pretty easy after axillary access.
Mark, can you specify what's your fear for having that catheter going chronically on the subclavian?
Well, we've had some patients that have had the 5.0 in for extended periods of time, that when we extract those catheters, there's a lot of fibrin and thrombus, and we've had some arm ischemia issues. So I'm concerned for, even though it's only a 9 French catheter and the repositioning sheath is removed, which is helpful, I think, to not have that in the axillary artery. But I'm concerned for an extended period of time, especially if you have a small axillary artery, relatively small, that it could be a problem.
Embolic stroke or, yeah.
Ischemia.
There was a question there.
Yeah, I think congratulations on using this new pump. I do want to lament on the fact that the chronic support, not just in recovery, but we've been able to use the Impella as a robust support for bridging to transplant, because it's getting balloon pump support is enough for some patients, but some don't last. We've had a 5.0 axillary up to 6 months, but then we've had to change 2 pumps because at some point you run into issue. And then the fact that having that catheter just the other day, as they're walking around, I think with their heart which is contracting, I had a case where the catheter is kind of in the mitral valve, and then you have MR and you're running into issues. So I think the longer support, one for recovery, two for bridging end-stage patients to transplant, hopefully will be a valuable addition.
Yeah, this will be more important now with the change of the allocation process in the US, for example, and also UK, for example. Yeah.
Okay, I think Ralph, as a final question, we're a little bit behind time.
Okay, one short question. Actually, did you ever think of a fully percutaneous approach to put this in this 8 French device? So like in TAVR, that you just do percutaneous puncture and maybe one suture with the ProGlide and then do the explantation surgically, then you could put it in awake patients, which could also move and ambulate afterwards? Or are there any criticism from the surgical side of you?
I mean, I'm a surgeon, and we are, at least Hamburg is...
but the patient was intubated, and I just an idea.
Yeah, I don't know, maybe do a lot of transaxillary TAVIs. I think last year we did, 50 transaxillary TAVIs using exactly that approach. I would be worried, I'm wondering to hear Mark's opinion on that. If you have it directly without the prosthesis, I would be worried that if it moves around, that there is quite a risk of arterial injury there.
I would agree. I think in the short term, for an acute procedure like the TAVI, I think it's a great approach. Or for they're doing it for high-risk PCIs with the per axillary. But for a chronic implant, I would be very concerned about it.
We're going to conclude. I think we're a bit behind. I thank all the presenters, the very nice opening to the renal field and very good presentations. Thank you all, and poster session back at 3 o'clock.